Okay, so I'll wait a minute whilst everybody comes into the room. And then I'll run through the rules of engagement for this evening. Okay, everybody's coming in. So I will start to go through the rules of engagement for this evening. Okay, this webinar is being recorded. No one can see that you're attending unless you would like to ask questions. So if you would like anonymity during the question and answers, please tick the box to send anonymously before sending your question. We hope to make this webinar as helpful to you all as possible. So please do ask your questions. Type your questions in the question and answer section. Please direct the questions to the panelists only, starting with the name of which panelist you're directing the question to. You may ask the question at any point, but they'll be answered after all the talks. If we don't get through your questions in the allocated time, which is 1 hour for this evening, we will answer them via email after the session. Remember, this is our beloved South Africa, so if there are any power interruptions or dodgy internet connection, which I've already had this evening, it must be Saturday streaming, please just bear with us. We'll resume proceedings as soon as possible. To this evening's, I'm so used to saying tonight, but we are on earlier today, so this evening's agenda, I'll give a short introduction. Then Dr. Lawrence Gobetz will be on from Vitalab. He'll be talking about egg freezing and oncofertility. Then Natasha Fagri will be doing her personal story. We will then have the question and answer session. I'd like to thank the sponsors for this session. It's Ferring Pharmaceuticals for helping us to educate the public about infertility. Your support helps us to break the silence, but it doesn't constitute an endorsement of any product or service by IFAASA, House of Fertility, or any of our speakers. Okay, so thank you to everyone for joining us this evening. This is our second last webinar of the inaugural National Infertility Awareness Week South Africa, where we'll be talking about egg freezing and oncofertility. My name is Saskia Williams, and I'm the founding director and CEO of IFAASA, the Infertility Awareness Association of South Africa. And we are bringing you this week in association with House of Fertility. During the course of this week, I've spoken to you about IFAASA and about House of Fertility and what we do, but I haven't yet taken the time to tell you why we do it. Put plain and simply, it's our passion. All of us have our own stories and our own journey to our families. None of it which were straightforward. None of our journeys were straightforward. But the one thing we all share is the wish that we had known more about the options out there before we even knew we needed them. That is what tonight's talk is about. It's about empowering women with knowledge about their fertility, potentially even before they are thinking about starting a family. So let's get started. Our first speaker is Dr. Lawrence Gobetz. Dr. Gobetz is a reproductive medicine specialist at Vitalab in Sandton. He's going to be talking to you about egg freezing and oncofertility. Over to you, Dr. Gobetz.
Thanks, Saskia. Well done. I just want to confirm, can you see my screen?
Yes, perfect.
Can you see my first slide? There we go.
Yeah.
Okay. Just welcome to everyone that's taken time out to listen on a Saturday afternoon after a difficult week that we have, and not just that we've had this week, but that we've had over many weeks now. And just to say, from a medical practitioner, I strongly believe we're all going to beat it and we're all going to come out on top, but we certainly are going to be living in a different world. So Saskia, thanks to IFAASA, House of Fertility, for inviting me to speak this afternoon. And yeah, I'm going to spend most of the time on egg freezing, and I will briefly touch on oncofertility as well. And please, afterwards, feel free to ask whatever questions you want to, because as I always say, no questions are silly questions. So this is the biggest issue when patients come to us and they say, Doc, will I have trouble conceiving? Now, we know that infertility affects probably close on 10% of couples in the reproductive age group, and even in the older female age group. And we'll qualify why older females are so important. And if we look at the data that we have to try and assess, you know, what is your normal potential? Because we normally on a day-to-day basis will only see patients that are having difficulty falling pregnant. So they would have tried for 2 or 3 years. They obviously have a problem. So when we're talking about trying to evaluate the couple or even a single woman, are you going to have difficulty? It is so easy because, I mean, it is so difficult because they haven't yet tried. And a lot of our data on spontaneous conceptions comes from the 1600s and the 1700s, and most people were dead by then. You know, if you go and visit graveyards adjacent to churches from the 1600s and 1700s, and you'll look at the headstones, you'll see most people by 40, 41, 42 were buried. So age on its own is not a perfect predictor of whether you will need infertility treatment at a given point within your relationship to conceive. If you become infertile, we know that infertility treatment becomes much less effective when the female is older. And it's important, therefore, to also identify if maybe you're going to need IVF later anyway. Perhaps your gynae has told you you've got blocked fallopian tubes. Maybe your partner, your male partner, had undescended testicles, or maybe he had mumps after puberty where he had an inflammation of his testes and was admitted to hospital for severe pain. Those are pointers towards, hang on, you know, I don't even have to, you know, think, am I going to conceive or not? I know I'm going to have trouble. So let's rather seek help earlier. So this is the most important thing to understand. And if we look here, bottom right is a picture, and it's an artist's picture of stem cells. And one thing that's vital is to know that no ovary has got stem cells to the best of our knowledge. And I know there's a lot of research ongoing trying to look for stem cells in ovaries. But the most important thing is this basket of eggs, top left here, with lots of eggs in it, is what your ovaries look like when you're in your mother's womb at 20 weeks. And these eggs, unfortunately, are genetically programmed to die off as you develop within your mother's womb. And at 20 weeks, you've probably got about 6 million eggs. And when you're born, that's down to 1 million. And when you get to puberty, it's on average about 350,000 eggs. And so what is happening is when you're getting older, the eggs that are with you are eggs that you had in your ovaries when you were in your mother's womb. They're not younger. And I know our 40-year-old females today are like our 20-year-old females 50 years ago. So if you start out in utero with this big basket, and then you look at the ovaries, when you get closer to 37, 38, 39, even 40, your basket starts to look like this basket in the middle. And we know that we can scan ovaries. And when we scan ovaries, if we look at the bottom left picture, we call these little black circles antral follicles. They are not cysts. Okay, and be careful of people or gynecologists telling you you've got polycystic ovaries because you've got very healthy looking ovaries. So this is what we call an antral follicle count, bottom left, and you can see that this ovary's got lots of antral follicles. These little structures are 5 to 8 millimeters in size, and each one houses an egg. Now, if you look at the ovary under the basket that has very few eggs, you can see the vast difference. Now, the left ovary would say to us, there's a good chance this patient should fall pregnant naturally, but the right, the bottom middle ovary says to us, this patient has got a problem, and this patient's egg reserve is very low. But what counts as a positive for the patient with the middle ovarian picture on ultrasound is if she is still young. Now, it's very hard to say to this patient, if it's a middle ultrasound, that, now listen, you better find a man now and go and get pregnant, because maybe in a year's time or 2 years' time, you may have no potential whatsoever. And the other thing is that if you look at this graph here on the right top above the stem cells, you'll see how this natural number of eggs drops right down. And that is why a woman ultimately goes into the menopause. Now, in my 31 years of doing reproductive medicine, I have my own theories on this, and I really believe that when you start to get to 35, your ovary hasn't changed. Your ovary doesn't know we have bridges, we build big buildings, we're now talking 5G, we've all got smartphones, we're all now Zooming. And your ovary, when you get into your late 30s, actually becomes your contraception. It's not going to give out good quality eggs. It does not want you to fall pregnant. So your ovary actually becomes your own contraception. And now, if we say, and it's one of the things that patients are now doing and asking the gynecologist to please check my egg count, doc, and tell me what's my potential. And besides doing a vaginal ultrasound, and I think it's imperative that every gynecologist seeing a woman for a pap smear, and these are, I'm talking young single women, and giving them contraceptive advice, they should already be looking at what their egg count looks like, specifically on ultrasound. But we talk of the hormone, anti-Müllerian hormone, or AMH, if you look at the graph on the left here. And if we look at the levels, and you must be careful, because there are two different units that we assess the AMH with. In South Africa, we do it in nanograms Ng per ml. And if you do it in picomoles, the level is much higher. So you must know what is the level that they're quoting you on. But if you look at this as a natural conception rate in 6 cycles, we have less than 0.7, 0.7 to 8.4, and greater than 8.4. If the patients wait for 6 cycles, there doesn't seem to be that much of a difference. And if they wait 12 cycles, again, so if you look at the cumulative probability on the left side of the graph of a conception within 6 months or 12 months, the AMH is very difficult to use as a predictor of whether you should or shouldn't freeze your eggs. And we'll come to what the AMH does mean to us, and what does the antral follicle count mean to us if we are going to put eggs in the freezer. And these are all very important contexts that you need to understand. Now, in the old days, we used to look at FSH levels. And FSH levels less than 10 would say to us, potentially the ovaries are still working well. And if your FSH was over 10, we would say, hang on, this is the brain getting a message back from the ovary to say, I'm not working as well as I should be. And therefore, the brain's trying to stimulate the ovary harder. And it also doesn't seem to be a predictor for us, absolutely, that you will have trouble conceiving. So we do know that as you get older, the AMH level declines. Why? Because at the end of the day, the AMH comes from those little black follicles that I showed you on ultrasound. And the more follicles you've got, the more AMH you're going to have. And the less follicles you're going to have, the lower your AMH level is going to be. So if we look at this AMH level and we look at the antral follicles, it is going to predict for us one thing only, and it's going to predict how you are going to respond when we stimulate you to recruit eggs from you, either to put in the freezer or to try and help you fall pregnant with IVF. So if you've got a low antral follicle count and we count 4 in each ovary, if we're going to stimulate you to put eggs in the freezer, we will not get more than 4 eggs from each ovary. If you've got 20 per ovary, there's a good chance we'll get 40 eggs from you in one cycle of stimulation. So on the one hand, we've got to be careful how we correlate a young woman who's nowhere near wanting to fall pregnant, but wants to put her eggs in the freezer. That AMH and that antral follicle count is really only going to help us to give you an idea of how many stimulations you'll need to get the right number of eggs in the freezer to then hopefully give you 1 or 2 children. So I divide the egg freezing process into 5 phases. Firstly, we need to evaluate your egg reserve. And all that, again, as I said to you, is going to tell us how many eggs we are going to get from you from one cycle of stimulation. And you need to know, when we count those antral follicles, that's how many eggs you have in the basket that we will get ready to then recover for you to put in the freezer. Now, in every woman, 100 to 1,000 eggs enter a race in every cycle, and one egg will win the race because your womb is made for one baby. And those eggs that are dying off, they are programmed to die. Your genetic programming happened when your father's sperm fertilized your mother's egg to make you. And there are some women that will lose eggs quicker than others. And what is also important, as I said to you, is the youthfulness of the eggs. So it is quality, not necessarily quantity, but you will appreciate just now why quantity is also important. So you need that initial investigation. We will then stimulate you. And as I said, those 100 to 1,000 eggs that enter a race, what we are really doing is we are recruiting or rescuing the eggs that are programmed to die off in that cycle. So we can only rescue as many of those black little holes we see in your ovaries to ripen over a period of 10 or 11 days. We then have to aspirate the eggs vaginally. We then need to prepare those eggs, and we then need to put them through a process where we extract the water from those eggs and we put in some antifreeze so we don't harm your eggs when we freeze them. And then they need to be placed into liquid nitrogen for storing purposes. And then you need to know, well, what's going to happen with my eggs at a later stage? If we need to thaw them, will they work? So there are various ways of stimulating, and those are protocols you will need to discuss with your reproductive medicine specialist. When we stimulate them, these little antral follicles now become dominant follicles because we've rescued them. And as you can see, this is probably about a day 8 scan on stimulation. And here you can see in this ovary 1, 2, 3, 4, 5, 6, 7, possibly 8 ovaries. Now, I mean 8 eggs, sorry. Now, when you look at this ovary, this is just a 2-dimensional view. So the doctor will have to rotate the probe through to almost get an understanding of, from a 3-dimensional point of view, how many eggs there are. You will be injecting yourself for somewhere between 10 and 11 days, roughly, under the skin injections. One thing that I can mention is that we need to think in terms of the total body. And under the skin injections don't work as well when your body mass index is elevated. And there you would rather give your injections intramuscularly and you will get a better response. We will scan you with a vaginal transducer, maybe twice or 3 times, possibly at the most, to have a look at these egg sacs, how they're growing. Each one of these follicles has a microscopic egg in it. You can't see the egg. So this follicle is not the egg. The egg is microscopic, and there's a direct correlation between the ripening of the egg and the size of the egg sac. And when all the eggs are now at a specific size and you've had your specific days of stimulation, we have to give the ovary a final maturation injection, which we call the trigger shot. Now, when we talk of the trigger shot, the patients think we're getting quite aggressive, and how are we going to do it? And is this with a pistol? And is my life at risk? And yes, your life is at risk, because if you have lots of eggs and we trigger you incorrectly, we will get lots of eggs from you, but we will be in big danger, and you are at high risk for developing ovarian hyperstimulation syndrome, which has in the past, and in my, as I say, 31 years, I know of people who unfortunately have died from this process, and you can go and Google it. Fortunately, I was never associated with a death, but I can tell you we were close to it. And it's the most horrific thing to see young girls who are, all they're doing is trying to put their fertility on hold, and here they are now in ICU with 1 foot in the grave and about to die. You should today, in today's times, in a good fertility unit, there should be absolutely zero risk of ovarian hyperstimulation when you are freezing your eggs, or even if you are doing IVF. So the egg retrieval is done vaginally. We give you some medication. So here's bottom right, you see the Zs. You have a little sleep for about 7 minutes. It's not a full anesthetic as such. We have a conscious sedationist adjacent who looks after you. And there, top right, you can see the needle where my cursor is. That needle is scored so we can see it. We pop it directly through the vagina. Okay, here is the probe. This convex structure here is the vaginal probe that's in the vagina, and we suck out this fluid, and this fluid gets trapped in this test tube, and this test tube goes to the embryologist, who has to then flip through the fluid under a microscope and find the egg. Now, the egg is microscopic. It is 0.0125 of a millimeter. We, having worked with it for a long time, know what it looks like with the light shining on it. It has a beautiful sheen. So it's quite simple for us to see it. But if you try and look at it with the naked eye, you will see absolutely nothing. So we've done all our preparation. We've got all our eggs. And now we need to freeze those eggs for you. So in the old days, we used to freeze with what we call a slow freeze method. And that method it damaged the eggs. It created a lot of ice crystals in the eggs, and those ice crystals damaged all the important structures within the egg, and we got very poor survival, and we really hardly ever got a pregnancy from it. And the vitrification technology on the right here is something that really only got off the ground properly throughout the world in about 2013, 2014. And there's a lot that we've learned since then. And vitrification, vitris is glass for Greek, or Greek for glass, should I say. And what happens is it's a very rapid freezing technology, and the egg gets frozen, and it looks like a little glass-like structure under the microscope. And it is frozen on what you can see here, a paddle. Now, the next thing is we have worked with vitrification now for quite a few years, and we realized that technically the time taken to get these eggs onto this paddle and dip it quickly into liquid nitrogen is absolutely crucial as to what the survival rate will be and what the quality of the eggs will be like when we warm them. Today, we certainly don't want to freeze more than 4 to 6 eggs on a paddle, because the more eggs you start putting on one paddle, the longer you're exposing these eggs outside to warming and losing qualities. And it is not ideal to say, well, I'm going to save my patient money and I'm going to put 12 eggs on one paddle, so I'm only going to have to charge you for 2 paddles for your 24 eggs. You must, please, when you do freeze your eggs, find out how many eggs per paddle are you going to do. And if they're saying to you, I'm going to freeze 12 eggs per paddle, I would prefer not for you to do that. Now, if we look at this and we say, okay, why do I need so many eggs? And by right, and I'll show you graphs just now for you to appreciate that in order for me to realize probably 1 live born from the eggs that I have in the freezer, it will depend on your egg age. And now we're talking about women under the age of 35. And here we're talking 15 mature eggs. Now, when we stimulate you, probably no more than 80% of the eggs that we get out from you are mature, and you will not freeze immature eggs because they will never able to be used. So the first thing is, if I get 20 eggs, I'm only going to expect about 15 or 16 of them to be mature. So those eggs can be put in the freezer, and now you want to know from the unit that you are freezing the eggs, if you warm these eggs, what percentage of the eggs will survive the freezing process? And any unit that's getting above 95%, you're doing exceptionally well. It's acceptable, 80 to 90% should make it. And then once those eggs have been warmed, what percentage of those eggs, when I want to use them, will actually fertilize normally? Now, any egg that is frozen has had all the shell, the eggs around it, the cells around the egg that are protective for the egg that are needed for IVF have been removed. So in order to use your eggs, you have to have ICSI. And once you have your 70% that have fertilized, how many of those embryos are going to become red apples on day 5 that I can actually use to put back in my womb? So we've gone from 15, we're now down to 5. And what we also need to know is, depending on the age that I froze my eggs, what percentage of those red apples are actually going to be chromosomally normal embryos that will be allowed or allow me to lead to a live birth. So if you freeze 15 eggs and you get down to 1 live birth, you have done well. Now, we've always used, not quite an algorithm, but we've always used the patient's age in order to try and understand, because of this funnel, how many eggs do I need to put in the freezer? If I'm 30 to have 2 babies, okay, I need to put 30 eggs in the freezer. And you can see here why that is so important. So the next thing is, should I freeze my eggs? Why? So, you know, as I've said, your egg number and quality decline now as you age. This happens, unfortunately for our modern woman, it happens much earlier than your ability to carry a pregnancy. So when you're 45, young and healthy, fit and strong, wearing your Nike tackies and doing your Virgin Active Health Club visits, which we don't do anymore, every 4 times a week, your womb does not necessarily age, but your eggs age. So younger eggs in your older womb will give you a far better chance of taking home a baby than older eggs in your older womb. And it's the same as egg donation here. In other words, what you are doing is you're putting your own eggs in the freezer to donate them to your older self. Now, if we look at the percentage of chromosomally normal embryos, and we look at it versus maternal age, this shows you why the younger you are, the more likely you will have genetically normal eggs that will give you genetically normal babies, and that is what you want. So when you start to get into your late 30s, early 40s, you start to the number of embryos that you have in the lab from a genetically normal point of view are going to be much less so genetically normal. And we know that for many years, we have always put genetically abnormal embryos back into uteruses. And that is where the concept comes that when you come for IVF and you're 34, and we say to you, put 2 embryos back because we haven't biopsied the embryos, we know that because we're hoping that 1 in 2 embryos are going to be normal. And at the end of the day, a lot of the time, the 2 embryos are genetically abnormal. It doesn't work. And the patients come and sit afterwards, and our chair is very hot because we have to explain to you why the procedure hasn't really worked. And in the meantime, unbeknown to us, we have put back genetic garbage, which has had no potential to implant. And the other thing that is very difficult to correlate is, what do these embryos look down the microscope? And everybody wants to know, what was the grading of my embryos? And we know that it's very difficult to correlate the grading and how their cells did over the 5 days, et cetera, with which embryos are going to be genetically normal. Now, if we look at the success rates in 42-year-old women with their own eggs versus donor eggs, you can see by this picture, okay, that our donor eggs are going to always give you a consistent 55, sometimes even 60% chance of falling pregnant in this lady who's 42 years old versus her own eggs that are probably going to give her a 3 to 5% chance that she'll take home a baby. So you must see yourself here. And you must see yourself then, well, if I'm going to put my eggs in the freezer, I'm doing it to be my own donor when I'm much older and when my chances of conceiving are much lower. And again, I say, I don't have a crystal ball. It's so hard to guide patients. But again, this graph shows us depending on your age and depending on the egg number, what is the live birth rate? And if we look at the bottom line, shows you the number of eggs, and this is where we get the 15 eggs from. And here we are. You can see there is a 2/3 difference between women 36 years and older getting pregnant with their own eggs. On the proviso, we can get somewhere between 10 and 15 eggs. Now, as you get older and as your store depletes, and if you have a basket of eggs, like I showed you initially, of only 4 eggs in each ovary, you will not get more than 8 eggs. And it doesn't matter how hard we stimulate you or how we do it. And you can see here already, before 8 eggs, we start to look, it kicks in usually at about 7 eggs when you're under 35. Okay, but when you're older than that, 36 and older, you start to run into trouble at 7 eggs, and you need to get a lot more eggs. So therefore, the older you are, the more expensive this is going to get, because the more times you're going to need to be stimulated to get the correct number of eggs in the freezer. And you must not be hoodwinked by the fact that you think 15 eggs equals 15 babies. It does not. So we have damn lies and we have statistics. And the female age and the natural decline in fertility, we know our data that we have is mostly not high quality, and it's not relevant, and it's very, very difficult. All we can say is that if you are going to need IVF, and whenever you freeze your eggs, you will need IVF. Obviously, there is a strong correlation between your outcome of IVF and the female age of the eggs, and that data is very well established. And your AMH will only predict how you may respond when we stimulate you for IVF. It will tell us nothing else. It will not tell us whether you meet Mr. Right in 6 months' time and you drop the contraception, whether you will fall pregnant or not. The other thing when you're freezing eggs is to try and understand the laboratory, because that's very important. And you as a patient have no idea of what's going on in the back room. And you do not know what the clinic's experience is at freezing and warming of eggs. And some clinics can freeze eggs well, but they cannot warm eggs well. And you need to know what the clinic's egg cryo survival rate is. In other words, if my eggs are warmed, what is the percentage of my eggs that will survive the freezing process? Okay. And we also need to know that somewhere between 1 and 10% in certain cases, and again, it's often related to technique, will not survive the freezing process. So be careful to be, to be in a thought process of the fact that I got 15 eggs in the freezer, and when I come to warm them, you need to be sure that the laboratory that did the freezing initially is actually daily running their own internal frozen egg donor program. So at Vitalab, we have Vita, and we run our own internal frozen egg donor program ever since 2013. And every day we have got frozen eggs that we are using for recipient couples that are giving us pregnancies. So it's extremely reassuring to be able to sit with our patients and say, you know what? Yes, if we look at frozen egg pregnancies, they are slightly lower, but not by much, than fresh eggs. But unless the unit that's freezing your eggs has an internal excellent frozen egg donor program, beware. Does the clinic track the success rates of their fresh donor egg program versus their frozen egg donor program? And that's very important. And as I said, we do see a slightly lower pregnancy rate with frozen eggs than fresh eggs. And I think that unfortunately will invariably be the case, although today in our unit, most of our transfers are frozen embryo transfers, and that's for other reasons which I won't go into now. So what ultimately is important is how good is the IVF lab that you are entrusting to freeze your eggs. And the questions you need to ask the clinic is the oocyte cryo survival for eggs, okay? And, when they've been frozen, when they've been thawed, what are their percentage rates? What are their success rates with frozen and fresh donor eggs? Do they run their own donor egg program that is extremely successful and very similar to fresh eggs? And are they exceptional at doing IVF if you at one day would need to use those eggs? If you look at the risks of egg freezing, and unfortunately today we still see ovarian hyperstimulation throughout the world. Again, I say I pride ourselves in our unit. We do not have ovarian hyperstimulation. You should not have it. It should not happen to you. And if it does happen to you, you're unfortunately in the wrong place. Is there any impact of freezing my eggs on my offspring? At the moment, we have long-standing data on frozen embryos. Our frozen egg pregnancy rates are still very young, but currently there seems to be no data that shows that there is any difference. In other words, no increased risk of abnormalities. In fact, for some reason, the freezing process seems to give us better babies and healthier babies, and we don't understand why. So just expect that if you want a vaginal delivery and you've had frozen embryos or frozen eggs utilized in the process, you may have a bigger baby and your doctor may have a reason to do a Caesar on you rather than allow you to go vaginally. Breast cancer, there does not seem to be an increased incidence in patients who are being stimulated. And in fact, women who've had breast cancer and have had 2 years free of disease, we can actually stimulate them and put their eggs in the freezer, provided their ovaries never suffered the effects of chemotherapy. But just to reassure you, no, an ovarian cancer from an egg freezing point of view, currently, again, I say it's very young, but we've seen it in IVF and we understand it in IVF that ovarian cancer and IVF, it's completely separate. It's not the IVF, it's the patients who have incessant ovulation. They've often had numerous IVF cycles of treatment. They still don't have babies. They've never breastfed. They haven't used the pill. So they have all the high risk scenarios of why they have increased risk for ovarian cancer. So IVF does not cause ovarian cancer. If we look at the costs of freezing eggs, and yes, it varies. It's going to depend on how many drugs we are going to need to stimulate you to get the required response we need. There's scans that you are going to have, 2 or 3 scans during the process. You will need to go to theater and have an egg retrieval under conscious sedation. There are the laboratory costs with the time involved and the skill involved and the special antifreeze media that we use for freezing the eggs. And then you will have, sorry for the spelling, an annual freezing cost. And if you were to freeze the eggs and in 6 months use the eggs, you would obviously get back a 6-month pro rata fee. Now, the biggest issue for us is our single women wanting to freeze their eggs. And there's always this question, Doc, should I freeze my eggs or should I rather freeze embryos? Because we get a lot of females who haven't yet found Mr. Right. They know that they're running out of good time from a biological point of view. And there's now pressure for them to say, well, you know, I need to freeze my eggs, but is it better that they freeze eggs or should they perhaps freeze embryos? Sorry, let me just get rid of this call. Okay. So one is that if you actually make embryos, you've got to choose your donor sperm. And what if you now do have embryos and you now have a partner who you're now going to marry and you now have embryos in the freezer with someone else's sperm? So it's not as clear cut. There's also maybe more clarity if you freeze embryos because at least you know your eggs are working and they're making embryos. And we also have today some patients who choose to do 50-50. They will freeze eggs and they'll freeze some embryos and they can then make that decision, will they or won't they use them later on. So prioritizing your child related to them, not worrying about being biologically related to a future partner is something that says to them, maybe I will freeze embryos. And they're considering to go it alone anyway. And there's better certainty in live burns if you don't really know whether your eggs are going to thaw and make you viable embryos. So I'm just going to move on now because the time's running out. There are legal and financial issues, and at the end of the day, freezing embryos is far more costly because you've got to go through the IVF process and you have to pay for the lab fee for that. And at the end of the day, freezing embryos can be either practical or there could be a lot of emotional issues which would direct you in the line of should I or shouldn't I. Now, oncofertility is a new field, and this is a field that we've got involved in, and we were a unit that got working together with Dr. Teresa Woodruff from Chicago. She is based at the Northwestern University, and she has spent her life now in infertility, dedicating it to exploring and expanding the options for reproductive future of cancer survivors. And we have an oncology setup within our unit that cancer patients are attended to immediately. We have a navigator who runs a cell phone, which is available 24/7. The cancer patients are seen almost immediately, and the entire process, if it's sperm, will be done in 2 days. And if it's eggs, it will be done over a period of 14 days. And then you have your eggs in the freezer, and you can continue with your oncology treatment. So there are various options. We can freeze eggs, we can freeze sperm, we can freeze embryos, we can take the ovaries and move them out of the field if you're going to need radiotherapy and keep your ovaries in, and they can then be utilized later for natural conception, or in young prepubertal females or women who cannot delay their chemo, we would then remove ovarian tissue and rather freeze ovarian tissue. So thank you, guys. Just to let you know, we do also have a clinic in Vitalab. So if we have in KZN, in Umhlanga Rocks, and if there's anyone online that comes from that area, there's our cell phone number and our email address. Feel free to contact us. Thank you.
Thanks, Dr. Gobetz. That was very, very interesting. Thank you. We do appreciate taking your time and giving us your expertise tonight as well. And there are a few questions, so we'll be getting to them after Natasha's spoken. Our next up is Natasha Fagri. Natasha is a business owner and entrepreneur, and this evening she's going to be telling us her personal story.
Thanks, Sas. Appreciate it. Well, firstly, guys, thank you so much for dialing into this. I'm conscious of the time, and unless you're on 57 hormone injections, I'm sure you all want to have a glass of wine. So I'm not going to take up too much of your time. But I kind of just wanted to chat to you a little bit about my journey, because I think one of the hardest things, and anyone, men and women alike who are on this call can attest to, is when you're walking this fertility journey, it can feel incredibly lonely. And there can be such an overwhelming volume of information that gets thrown your way. And sometimes just hearing someone and what they've gone through can kind of show that you can come out on the other side, and it's not as terrifying as it may sound. Okay, so the first thing I just wanted to say is, you know, we spend large portions of our lives, just speaking from a woman's perspective, trying not to get pregnant, you know, because you might not be ready. And then usually what happens is the point that you think, maybe I want to have a baby one day, or what's the right time, that's when you tend to maybe find out that, oh my goodness, my egg reserve has dropped. And something I do want to stress, because I've seen it, and it's something that my doctor advised as well, and it really put my mind at ease, is no two patients are identical. I have seen friends of mine in their late 20s struggle to fall pregnant, and then I've got friends in their early 40s that fell pregnant first time, no issue. And I'm kind of 36, right in the middle, and I'm like, Jesus, take the wheel, I'm having a hell of a time. But you know, it's helpful to know that everyone's case is unique. So to give a little bit of background of why I decided to go down the egg freezing route, I don't have a straightforward story at all. In February 2015, I was diagnosed with stage 4 endometriosis. I had an op for it. It came back in August 2018. Then it was stage 4 severe. And just to put some context into things, because I think there is a big misconception around things you might struggle with as a woman or a man associated with lifestyle. Lifestyle is incredibly important, absolutely. You know, by no means advocating that you go and do anything drastic and destructive, but I've always been healthy. I've never been a big drinker. I've always looked after myself. I've never had any major medical scares, and yet I was encountering all these challenges, which you just don't think that you would ever do if you've lived relatively healthy, which kind of reinforces this can happen to anyone. I then went for a checkup in September last year, and we discovered that my AMH levels had dipped dangerously low, and quite dramatically so compared to a year before. And I got quite a big shock because I hadn't had any major change in lifestyle. As I mentioned, I hadn't, been, overly stressed, but it dipped. And, my fertility specialist said to me, look, I think you should consider freezing your eggs. And I thought long and hard about it. And even though I'm in a committed relationship, I thought, good idea. There's a few things coming up, not quite ready to have a baby right now. So I was going overseas for work. And when I came back in January, sort of our position had changed, and I'd kind of taken the decision that I want to harvest eggs, but I'd like to also freeze embryos, if possible. So I went through the hormone stimulation process, and then the aspiration to harvest the eggs. And I came out with 10 eggs. And out of those 10 eggs, as Dr. Gobetz mentioned, if you're going to go the embryo freezing route, and the advice I was given, and again, it might be unique to everyone, was if you've got the option to freeze embryos, because the advice I was given is they tend to fare a little bit better. But if I wasn't in a relationship and I didn't want to have a baby at that time, I 100% would have just frozen my eggs without a doubt. Out of the 10 eggs, 4 of them got to blastocyst stage, which is obviously the 5th day after they'd been fertilized. And we actually, as a couple, took the decision to do some pre-genetic testing. There weren't any issues that I was worried about, but I think when you've come that far, if you can afford to do it and you want that extra peace of mind, I thought it was a good idea, because at least then I knew I was working with chromosomally normal embryos. That was just something that I wanted to know. And I'm really glad that I ended up going that route, because out of the 5 embryos, only 1 was chromosomally normal. And our initial plan was actually only to test 2, and we ended up doing all of them, and only 1 came out as chromosomally normal, which meant after all of that, we sat with 1 chance at that point. During this whole cycle, we actually took the decision that instead of freezing, we wanted to actually do a transfer sooner rather than later. So sorry, that's a bit of an error. Actually, we did end up freezing that embryo, but we decided to do the transfer within 2 months of freezing. So it was thawed. I went through the transfer. And unfortunately, it didn't take, and it had nothing to do with the embryo at all. My uterus, through all the scans, was normal. We'd done everything right. It just didn't take. And I know this is slightly off topic, but as I mentioned to Saskia, I think it's important to mention the side of things, because you can do everything right and everything can be chromosomally normal and it can still not work. But that's not the end of the road by any stretch. Again, why I say it's so important who you choose to be your doctor, because having someone who's totally invested in your journey and who doesn't make you feel like you're 103 or that there's something wrong with you makes the world of difference. And my doctor gave the most incredible advice. He advised that I get a special blood test done where things called antibodies and natural killers get measured. Those are just different types of bloods. He recommended these really, really great new tests called Alice and Emma, which look at the bacterial levels in your uterus. And then he also recommended what's known as an ERA test, which checks if your implantation window falls within the most common sort of day or whether you might be a little bit left of center. And very lastly, he recommended a hysteroscopy to just make doubly sure there isn't any little something that's lurking in the uterus, the womb area that you can't pick up on a scan. And I'm so glad that I followed the advice, because true to form, there was a little niggle on every single level and a few little things that were found, but they were all fixable. There was a course of medication that I can go on to rectify my natural killer cells. The ERA came out as normal. The Alice and the Emma came out as normal. And the hysteroscopy, they actually found that I had a uterine septum, which could easily be removed. And now I'm ready to go into, in the next month, a second round of IVF, just feeling more informed, more ready. Yes, of course, it was disappointing. And the idea of becoming the human pincushion again with all of the injections. I had to get my head around that again. But I feel confident that maybe anything that might have contributed to the first failure, we've now kind of learned more and ironed out more obstacles. So I think just in closing, my best piece of advice, and I've had a lot of chats with friends about this because there's a few of us in my friendship group who are in a similar situation. Be informed, but don't like drown yourself in information. Find a doctor that you trust and you feel comfortable with, and know what your body is saying. And, you know, if you're at that point where you're wondering and you're not sure, you know, I'm an absolute advocate of egg freezing. As I mentioned, it's the route I was going to go down. And, you know, it's always nice to know that you have a little bit of a guarantee, because as women, you know, we want to do different things in life, and times have changed. Not all of us are having babies super young, and we have the right to make that choice. And that's pretty much it. That's my story in a nutshell. So you're welcome to ask anything you like, and I will answer as best as I can.
Thanks, Tash. And thank you for always being so open about your journey and being such a great advocate for speaking out and telling your story, as well as helping us, obviously, as we continue our fight with the medical aids for fair cover like you do. So we really do appreciate everything that you do. Thank
No problem.
you. Okay, there are a few questions. I'm going to start with one, Dr. Gobetz, that came in via email before the session. This lady asks, number one, there's two questions. I would like to know how combined oral contraceptives might affect egg amount or quality. What would the optimal duration to stop them before going for ovarian stimulation to get the highest number and quality of eggs?
That's a very good question. And again, it goes back to, sorry, let me just share my screen again. Otherwise, you're going to see a lot of other things. You there?
Yeah.
I'm there. Hey, okay. So the most important thing to understand is that when you're on the pill, that genetic programming of cell death, where you are losing eggs every month since you were in your mother's womb at 20 weeks, does not get slowed down by being on the oral contraceptive. All the oral contraceptive does is it stops you from ovulating one egg every month. It cannot retard the loss of eggs. So number one, to take an oral contraceptive and feel, because I've been on the pill for 20 years, I should have more eggs, is not correct. Secondly, we are pretty sure of it that, and we've watched this for many years, and there are some units that will say, you know what, the oral contraceptive is going to decrease your response, and therefore we shouldn't use it beforehand. In some patients, we may make that decision. In a lot of patients, we use the pill before IVF or before egg stimulation because it helps us to plan the cycles so that you don't end up being number 20 on a Monday and then we only do 3 cases on a Tuesday. And it does not seem to negatively affect one's ability. So be careful not to think that the pill is going to slow down my egg loss. It doesn't.
Okay, perfect. And then her second question is, how many eggs are usually harvested per session, and how many would be advised to harvest in total per child planned? I think you ran through that in your presentation.
I did, and I think again, it depends on egg age, and the unfortunate thing is that as you get older, your antral follicle count goes down, and the antral follicle count together with your AMH level is going to give us a good idea of how many eggs per cycle we will get from you. And obviously, as I showed, the older you are, the more eggs you need. The younger you are, the easier it is to get more eggs. So you should really, if you're thinking in terms of freezing your eggs, try and do it before 32 years old. And unfortunately, the women that come forward now to freeze eggs are your women who are 38, 39, and 40 who realize they haven't yet found Mr. Right. They're running out of time and they better put their eggs in the freezer. And again, I advocate strongly that you discuss this with the doctor, because you should not be seen as a pulse and a credit card. You know, because the doctor may say, okay, 5 eggs in the freezer are better than no eggs. But you may need to be counseled towards the fact that, you know what, you possibly are going to have to rather look at other alternatives later on when the right man comes along and you're 45, and that's going to be acceptance, adoption, which is going to be extremely difficult because of a female age of 45, but you can still look at egg donation. And as I showed you on my one slide, egg donation at 45, you ain't going to get a chance to take home a live baby with your own eggs. So at the end of the day, if you haven't put your eggs in the freezer and you've only got 2 or 3 antral follicles, it's debatable whether you should put those eggs in the freezer and rather be counseled towards egg donation. But some patients will say, Doc, I'm happy. 3 eggs for me are better than no eggs. But unfortunately, patients think that 1 egg equals 1 baby. It doesn't. And as Natasha showed you, a genetically normal embryo does not confirm implantation. And we must understand that that's just one little aspect of the embryo that we actually understand. But there's a lot of things that we don't know about that embryo that could be abnormal. And that is why nature is not allowing the implantation. So informed consent is vital. And the doctor should be able to answer all your questions correctly and should give you the right idea of what the outcome is going to be. I know we're not fortune tellers. I know we don't have a crystal ball. It's not an easy one. And we have to say we've got 2 issues here. We've got a practical issue and we've got an emotional issue. And I think in the reproductively older woman, one should get a counselor involved as well, because it's not as simple as, well, I'm now happy because I got 5 eggs in the freezer and I'm 40.
Thank you. Thank you, Dr. Gobetz. There's a question here. I think it's pretty straightforward, but Dr. Gobetz, do my eggs age as the years go by, or do they stay the same age as the day they were frozen? I mean, you answered that as well.
Answered that. In other words, I said to you, you become your own egg donor. So now you're 10 years older than what you were when you froze your eggs. So if you were 24 at the time that you froze your eggs and you are now 44 and you're using those 24-year-old eggs, your potential to achieve a pregnancy are equal to your age potential at the time that you froze your eggs.
Perfect. Thank you. Natasha, there's a question for you. They're asking you whether your medical aid has covered your process.
My favorite question. So no, large portions, oh, let me start my video, sorry. Large portions, the majority of the process has not been covered. The only thing that the medical aid covered, and it was actually quite a small portion from the medical aid and my gap cover picked up the rest, was my hysteroscopy that I had recently. That was it. At the moment, there are no medical aids that are willing to cover IVF process, ovarian stimulation, anything to do with egg freezing at all. So as Saskia mentioned, you know, we're fighting that battle, but we're not there yet.
Thank you. We are definitely fighting that battle and we will get there. We will definitely get there. Okay, Dr. Gobetz, is it better to freeze eggs or freezing embryos?
Yeah, I think if you're going to a very good unit that gets pregnancy rates very similar with their frozen eggs as what they get with fresh eggs, it is the only thing that's more costly is if you freeze eggs, because somewhere along the line, you're going to have to warm the eggs and then do IVF. Now, you don't know because of those eggs, and depending on the age of the patient when you're freezing the eggs, what you don't know is what number of eggs are going to give us live babies. Whereas if you let the eggs fertilize and you let the natural selection take place in the laboratory, you will end up freezing probably, if you're lucky, 1/3 of the number of eggs that you would have had to freeze. But your cost related to doing the IVF procedure is more expensive than your cost in egg freezing. So if you're going to freeze eggs rather than embryos, for me, it would be dependent which unit are you at, and does that unit get better results with frozen embryos than what they get with frozen eggs? And if that is the case, they will probably encourage their patients to rather freeze embryos. Now, freezing embryos is easier when you are in a relationship and you've decided that this is the right computer that you're going to work with for the rest of your life. You know, most days today, you're with the computer for 5 years and then out goes the computer, and then you go to Incredible Connection and you buy a new computer. And by the time you settle down and made sure that you now want to start falling pregnant, you're in your 40s. So it's a very difficult one to answer, Saskia. And there are some slides that I have in my talk that I didn't really spend time on, which I'm happy to share that with you so you can let the patients have those slides. But at the end of the day, it's a cost issue, and it's issue of, do I have a partner in my relationship, and is the partner that I want to have that's going to father my child? And if it's not, and if it's a partner who's just going to be a donor for you, please, it's an open scenario. Make sure that you have the right legal consent forms in place. You need a lawyer involved, because you may not want this partner to have any rights to your offspring. And if you do not have that in place, it's going to cost you a lot of money in court and legal battles later on.
Perfect. Thank you, Dr. Gobetz. If we haven't got to your questions tonight, because it is 6 o'clock, just gone 6 o'clock, please email them to me, saskia@ifaasa.co.za, and I will get them answered for you. So it's time to wrap up. It went super fast this evening. What I wanted to say is thank you to all the attendees for joining us and for taking charge of your fertility. Tomorrow is our final talk, and we'll be talking about the emotional subject that is pregnancy and baby loss. As always, please register on our website, www.niaw.co.za. And remember, you can catch a recording of this webinar from tomorrow and all the others from this week on our YouTube channel. Thank you again to our sponsors for our webinar tonight, that's Ferring Pharmaceuticals, and to our headline sponsors for the week, 360 Biomedicine. But the biggest thank you must go to you, Dr. Gobetz, and to Natasha, for giving of your time, your expertise, and your personal journeys tonight. We really do appreciate it, and I know you've all helped somebody out there and made their journey a little bit easier. So thank you. We do appreciate it.
Thanks,
All right.
thanks, Saskia.
Take care. Keep safe.
Good evening, everyone.